Hello, wisdom. So you're finally here. I thought you were a myth. I thought I'll be destined to be wisdom deprived. But you're finally here at the back of my mouth, and the pain of your entrance wouldn't let me go out. Yes. Today I'm going to talk about wisdom tooth, that is, impacted tooth and its surgical management. By definition, the topics that we'll be covering are the definition, etiology, the order of frequency of impaction, the complication of retained impacted tooth, indication for removal, and in detail about the surgical treatment of impacted mandibular third molar, that is, its classification, assessment, both clinical as well as radiographical assessment, surgical procedures. This would be followed by the impaction of the maxillary third molar and the surgery associated with removal of the maxillary canine, complication of the removal of impacted tooth, and conclusion. So by definition, an impacted tooth is a tooth that has failed to completely or partly erupt into its correct position in the dental arch and its eruption potential has been lost. Now a tooth could either be partly impacted, as you can see in the picture, you can see a half part of the crown and rest embedded inside, or it could be completely bony impaction. You could not see the tooth intraorally, or on the radiograph you will see that the tooth is covered with bone and soft tissue. Now, etiology of this impaction could either be local factors or systemic factors. Local factors can be because of an obstruction. Now, the obstruction can be because of the adjacent second molar position. If the second molar is tilted distally, the part of eruption of the third molar is interrupted. Or it could be because of the obstruction caused by the dense cortical bone, which is not getting resolved, because of which the tooth is impacted. There could be lack of space between the second molar and the anterior border of ramus for the eruption. Or there could be an ankylosis of the primary tooth, or the primary tooth is retained, over-retained decidusly. Or there could be ectopic position of the tooth bud that could result in impaction, or associated soft tissue or a bony tissue pathology that could result in an impacted tooth. Systemic factor can be prenatal, that is congenital. It could be postnatal because of malnutrition, deficiency of vitamins B complex. It could be because of endocrine disorders like hyperthyroid or parathyroid, because of which the osteoclastic activity is decreased, because of which the bone doesn't resolve and the tooth get impacted. Let's move on to the order of frequency of impaction of the tooth that is most commonly seen in the oral cavity. The descending order is that the mandibular third molar is more commonly impacted, followed by the maxillary third molar. Then we have the maxillary canine, the mandibular premolar, the mandibular canine, followed by this is maxillary premolar, maxillary lateral incisor, central incisor, and then the lateral incisors. Let's move on to the complication that can arise if these impacted teeth are retained. What happens is that if the third molar is retained, it causes food lodgement in that area. Because of food lodgement, if it is partly erupted, the food keeps on getting lodged into the soft tissue, which results in inflammation and pericoronitis. Pericoronitis is nothing but, peri is around, coronitis is crown. Okay, around the crown there is an infection or inflammation, that is pericoronitis. Now this pericoronitis eventually can cause decay of the third molar, or it could cause decay of the adjacent second molar. This eventually results in severe pain. Because of the pain and inflammatory exudate, there is trismus, that is decreased mouth opening. Then most of the time these third molars, or you can say impacted tooth, are associated with cyst. If you see a dental follicle larger than 3 mm, then you should always suspect it could be a cyst. Now these third molars can weaken the mandible at the angle region and can cause fracture of the angle region because of any kind of trauma. Now these are the indication, these are the reason why you need to extract the tooth. Let's move on to the definitive indication of removal of an impacted tooth. When there is a recurrent pericoronitis, pain, infection and dental caries, you have to remove the tooth. When there is a deep periodontal pocket adjacent to second molar, in that case you have to remove the third molar. If you're planning for an orthodontic treatment and you need space to mobilize the anterior crowding, in that case you can extract the third molars. If the third molars are associated with cyst, tumor, in that case you need to remove the third molars. Presence of any pathological fracture, The line, if the tooth is present in the line of fracture, you need to remove the tooth because it can cause a nidus of infection and will cause malunion of the fracture. If it is associated with the impacted in orthodontic treatment, as I mentioned earlier, you need to remove the third molars, or in case of prophylactic removal of third molars. Now let's move on to the contraindication of removal of third molar. It could be local contraindication and systemic. Local contraindication, if there is an adequate space. If you think the third molar can erupt, take a time, let it erupt. If it doesn't erupt, then we can extract it. If there are chances that it could cause damage to vital structure, that is, it is very close to the inferior alveolar canal and it is asymptomatic, or it is very close to the maxillary sinus and asymptomatic, then you need to leave the third molars. No need to extract it. If it is associated with acute gingivitis, here we need to correct the gingivitis first, then treat the third molars. And for prosthetic consideration, wherein the second molar is missing and you have a first molar, you can bring the third molar into the occlusion, or you can, with the help of third molar, you can make a bridge and fill that gap. In case of systemic condition, that is, if the patient physical state is compromised, that is uncontrolled diabetes and hypertension, or patient is on anticoagulant therapy, so in that case we could defer the surgical extraction, or if the patient compliance is not good. Let's move on to the impacted mandibular third molars. We begin with the classification first. Winter has classified mandibular third molar depending upon two criteria. One is the angulation, the other is the depth. In case of the angulation, the position of the third molar is assessed depending upon the long axis of the second molar. And in case of the depth, you see the relationship of the occlusal surface of the second molar and the third molar. Based upon this, Winter has classified mandibular third molars as mesioangular, distoangular, vertical, horizontal, buccolingual, lingual and inverted, as you can see in the photograph. Mesioangular impaction are most common impaction, of which 43% of the mandibular third molars are mesioangular, whereas 63% of the maxillary third molars are mesioangular. Let's move on to the depth classification depending upon the position. In case of positioning, the occlusal surface of mandibular third molar is same as that of occlusal surface of the second molar. In case of position B, the mandibular third molar is below the occlusal surface of second molar but above the cemento-enamel junction. In case of position C, the mandibular third molar is below the cemento-enamel junction. Pell and Grigor has further classified mandibular third molars depending upon the ramus and the second molar into three classes. Class 1, where there is sufficient space between the second molar and the ramus so that the third molar can erupt. Class 2, where the space between the second molar and the ramus is not sufficient for eruption of third molar. And class 3, where the third molar is completely embedded into the body and the ramus. Let's move on to the preoperative assessment. We always begin with case history. So the patient will always come to you with a complaint of severe pain and difficulty in mouth opening on the affected side. Okay, most of this time this is the main cause. Few cases the patient will be referred to you from an orthodontist that for orthodontic treatment you need to extract. And very few, around 5 to 4% of the patient will come asymptomatic removal of third molar because they might be complaining of back pain and neck pain. So because the pain of the third molar can radiate to these regions. So in these cases, you have to rule out any other pathological condition, then come to a diagnosis, then this is because of third molar, then go ahead with the extraction. After history, we move on to the clinical assessment. The patient, you will see swelling or facial asymmetry. The mouth opening will be restricted. There will be trismus because of the pericoronitis. And there will be pocket distal to the second molar, and oral hygiene will be very poor. Then you do a radiographic assessment. Now, radiographic assessment will help you to find out the type of impaction. It is mesioangular, distoangular, and it also will help you to find the axis. Now, axis is determined radiographically by checking the inclination of the external oblique ridge. If the tooth is covered by the external oblique ridge, that is, there is an amount of bone that is covering the tooth. You need to do a lot of bone drilling. Then, radiograph also help us to assess if there is any kind of presence of existing pathologies associated with the tooth. You can also see the crown of the tooth. If it is more bulbous or a narrow crown, this will determine the difficulty index. Then radiograph also help us to check on the root pattern of the third molar, which is very important to see the length of the root. 2/3 of the root formed is good for extraction. If less than 1/3 of the root is formed, then the extraction is difficult. The tooth will rotate into the socket like a ball and you will not be able to elevate it. Then after this, you need to see the curvature of the root, whether the curvature is favorable or non-favorable. What I mean by favorable is that the curvature should be along the path of the exit, eruption of the tooth. That is a favorable curvature. Unfavorable is it is against the path of eruption. So while elevating it, you might fracture the apical third of the root. Then you also have to see whether the root are dilacerated, whether the root are fused or not, or whether the root are bulbous. If it is dilated, the extraction is difficult. If the root are bulbous, the extraction is difficult. If the root is cylinder also, then also the extraction is difficult because you might fracture the apical 1/3. After that, you check the texture of the bone. You see the cancellous. Now in case of young age children, the bone is more cancellous and elastic. And in case of the adult, the bone is more sclerotic and dense. Now how will you see the cancellous and the dense part? When you see the texture, you will see the size of the cancellous space and the density of the cortical bone. If this cancellous space is large and bone structure is fine, then it is elastic. If this cancellous space is small and lot of bone is there, then it is sclerotic. Then you also assess the proximity of third molar to the inferior alveolar canal. There are various radiographic identification criteria that you need to see to confirm that whether the tooth is very close to the canal. As you can see in this photograph, there is darkening of the apex of the root, which shows the proximity of the root to the canal. There is deflection of the root, narrowing of the root, darkening and bifid apex. There is interruption of the white line of the canal, deviation of the canal and narrowing of the canal. Whenever you see any of these conditions in a radiograph, you should always suspect that the tooth is very close to the inferior alveolar canal or it is sometime into the canal. So a conventional radiograph is not very suitable in this kind. Nowadays, CBCT is used. Now, CBCT is nothing but cone beam computed tomography. It will give you a thin section and tell you whether exactly the root is in the canal or it is away from the canal or it is closely approximated to the canal. We all should also see the position of second molar when you are assessing the radiograph. What happens is that the second molar, if the roots are conical or fused, when you're trying to elevate the third molar, you might elevate the second molar if you're using the tooth as a fulcrum. Always keep in mind, as I mentioned in my earlier lecture of extraction, the bone should be used as a fulcrum, never a tooth. So you should keep that in mind. Then after seeing the radiograph, we'll do the assessment of difficulty of extraction of third molar. This is also done on a radiograph. More preferably it is done on an IOPA because the image distortion is less of IOPA by using a parallel technique compared to an OPG, and superimposition is less. So here we assess the war lines of Winters. Now Winter has given this three imaginary lines. W stands for the white line, which is nothing but the occlusal surface of the molar and extended behind. A stands for the amber line. This will correspond to the interseptal bone present between the molars and extend posterior to the anterior ramus. Then you have the red, that is the R stand for the red line, which is nothing but an imaginary line drawn perpendicular to the amber line. It will denote the path of placement of an elevator. Whenever this red line is less than 5 mm, the extraction is easy and can be done under local anesthesia. If it is more than 5 mm, extraction is difficult, need to be done under local or general anesthesia. Okay. Now, if it is below the apices of the third molar, it is a very second molar. It is very difficult extraction and you need to do it under general anesthesia. Now, Peterson has given a difficulty index. What he has done, he has scored the different type of classification by numbers and given it a score that this is difficult, this is easy. Okay, as in he has scored the types of angulation, wherein mesoangular is the easiest one, that is 1. Horizontal, he is graded as 2, vertical as 3 and distoangular as most difficult 4. The depth he is classified level A as 1, level B as 2, level C as 3. Then the class classification, he has class 1 is termed as 1, class 2 is numbered as 2 and 3 as 3. For example, if it is a distoangular, level B and class 2 type of impaction. So since it is distoangular, you will number it as 4. It is level B, you will number it as 2. And it is class 2, you will number it as 2. So the total winds up to 8. Okay. So if your score is 3 to 4, it is minimally difficult extraction. If your score is from 5 to 7, moderately difficult. If the score is from 7 to 10, it is very difficult extraction. So here in this example, our score is 8. So it is a difficult extraction. Then McGregor in 1985 have given another assessment. McGregor not only involved the angle and the depth, but other important criteria like the height of the mandible, the angulation of the second molar, the root shape and the follicle into the assessment to help the beginners to anticipate the problem and to avoid them during third molar surgery. Now he has termed this as WAF assessment. WAF is nothing but wherein W stands for Winters classification, H stands for the height of the mandible, A stands for the angulation of second molar, R stands for the root shape, F stands for the follicular size, and E stands for the exit. The total score comes to around 33. So depending upon this, you add up the score and find the difficulty. Now let's just take a look at the factors that are responsible to increase the difficulty of the third molar extraction. One is the angulation. The more is the angulation, the more difficult is the surgical removal of the impacted third molar. The depth, the deeper it is seated inside, more amount of bone you have to drill. You're making the mandible weak and the deeper difficult is the extraction. The space available for eruption, lesser the space available, you need to remove more bone, difficult. Crown size, bulbous crown are difficult to remove. Root configuration is very important. The texture of the bone, as I mentioned earlier. If the bone is elastic, it is easier, pliable. If the bone is sclerotic, very difficult to drill. Then the size of the follicle also make a lot of difference. The space relationship between the mandibular second molar is also important. Relationship to the inferior alveolar canal also make a difference, increase the difficulty index of third molar. Gag reflex also increase the difficulty of removal of third molars. Let's move on to the surgical management of mandibular third molars. Here you can just list the surgical procedure that can be done. First is the access to the underlying bone and soft tissue. Now this can be achieved through use of a soft tissue flap. After you have designed a soft tissue flap, you need a complete mucoperiosteal elevation. Once you have done a complete mucoperiosteal elevation, you need to drill the bone to expose the ground till the cemento-enamel junction. Once you have done that, apply elevator, remove the tooth, or you can section the tooth and remove it. Irrigate the socket, remove any sharp edges, sutured irrigation. Let's move on to the flap design. We begin with the first flap, which is most commonly used as the Ward's incision. Now Ward's incision has 3 limbs. Limb A is the anterior limb. It is around 1.5 to 1 centimeter in length. Start from the buccal vestibule, extend anteriorly upward towards the distobuccal margin of the second molar. Then from there starts the limb 2, that is the clavicular incision around the third molar. Then start the limb 3, that is the distal releasing incision, which is taken more towards the cheek in the mucosal plane. Okay. Now there are a number of modification of these incision. When you need a wider access or the tooth is embedded deep inside, when you need more amount of exposure, then you can increase this length of the incision. That is, rather than starting from the distobuccal line angle of second molar, you could start from the distobuccal line angle of the first molar so that the access is increased. And you can vary the length to 1.5 to 2 centimeters. Now the next flap is the envelope flap. Envelope flap, as the name suggests, there is no releasing incision as such. You start from the first premolars, from the mesial aspect to the second molar, first molar, second molar, come to the distal aspect of the second molar and then give a distal incision. Here is how the envelope flap is raised. You can see in the photograph. The next flap is the C-shaped flap or a comma flap. Now this case is used in case where there is only soft tissue impaction, where the bone is covered by the tooth is covered by the mucosa only, not the bone. So you will do a reverse C shape in the buccal attached gingiva and extend it towards the distal portion. Here the flap is basically based on the distolingual mucosa. You raise the flap and remove the tooth. Now this is how the ward incision look, and this is how the envelope incision look, as you can see in the photograph. Reflection, the amount of exposure you can achieve with each of the incision. After you have exposed the bone, reflected the flap, secured it properly, you need to drill the bone. Okay, now we need to drill the bone to expose the crown, to remove the bone that is obstructing the path of removal, and to form a fulcrum. Now bone drilling can be done either with a high speed, high torque handpiece and burr technique, or with a chisel and mallet technique. Now how does bone is removed? Now, how much do we need to remove the bone to remove a tooth? Bone should be removed till the highest point of contour, that is till the cemento-enamel junction, till the widest diameter of the tooth, below the widest diameter of the tooth, so that you can put an elevator and remove it. Now the amber line will determine the amount of bone that is needed to be removed. When the entire crown is above and in front of the amber line, no bone removal is required. Now when you're using a burr technique, you use a 45-degree angle handpiece. You use a 7 mm long diameter 1.5 mm burr to drill a buccal gutter or to remove any kind of bony hindrance that is present. As you create a buccal gutter, if you want to do a gross trimming, then you use a rose head burr, which is size number 2, or you could also use a fissure number 7 burr. Okay, you do the bone guttering till the cemento enamel junction. Now always keep in mind that the bone belongs to the patient and tooth belong to the surgeon. Avoid bone guttering. Section the tooth and remove it. Make it more comfortable to the patient. The advantage is that if you section it, you do not trim the bone. The time is decreased. The damage to the adjacent tooth is decreased. Okay, the risk of fracturing the jaw is decreased. The risk of damaging the inferior alveolar nerve is decreased. But it has its own disadvantage. Elderly patient, it is very difficult to split a tooth because there is sclerosis that has taken place in the tooth. Now, due to presence of a shallow groove on the tooth, the splitting becomes difficult sometimes. Okay. Now, depending upon the angulation of the tooth or depending upon the impaction, splitting can be varied. As you can see in this photograph, in case of a horizontally impacted tooth, you need to remove the crown first. Once you have removed the crown, split the furcation area, remove the tooth singly. In case of vertical impaction, you section the tooth along the long axis, make it into 2 halves and remove it. In case of a distoangular impaction, you remove the crown and then the root. In case of mesoangular, remove the portion of the crown that is hindering the path of eruption and then remove the rest part of the tooth, as you can see in the photograph. The next technique that could be used is lateral Striffing technique. This technique was described by Henry. Now this is basically used to remove a deep impacted tooth when the child is young, at about the age of 9 to 16 years, wherein the bone is more elastic. So herein, what you will do is you will give a lazy S incision starting from the retromolar area towards the buccal vestibule, keeping a cuff of mucosa of around 5 mm attached, that is attached gingiva. You are saving the mucosa, and this will prevent periodontal pocket distal to second molar. Now once you have done that, you will use a trephine and make holes on the cortical plate. Once you have made holes on the cortical plate just above the tooth where it is present, you will make with a straight burr, you will make horizontal divergent cut on both the side. Once you have made the divergent cut, you will put your chisel in that hole and try to fracture the cortical plate. Once you have fractured the buccal cortical plate, the tooth will be seen. You will remove the tooth, put the cortical plate back and then suture it. The next is the lingual split technique. In the lingual split technique, you will give similarly Ward's incision or modified Ward incision. After giving Ward incision, you will make first vertical stop cut on the buccal cortical plate, which is around 5 mm with a 3 mm chisel. After you make this first vertical stop cut, you will make the second vertical stop cut distal to your third molar. Okay, once you have made the third stop cut, you will join this first and second vertical stop cut with a chisel. Okay, and then fracture it, remove the buccal cortical plate. Once you have done this, you will take a chisel, keep it at 45-degree angle on the distolingual cortical plate and try to fracture it. You will try to fracture it in such a way that it is attached to the periosteum. In this way, you will expose the bone and you can remove the tooth. Okay, put back the bone and then suture it. Again, this case can be used only in case of elastic bone in young children. Advantage is that faster tooth removal, you don't have to drill the bone, you're preserving the bone and the contour. Less risk of injuring to the inferior alveolar nerve, you're actually doing a saucerization of the socket and decrease the damage to the periodontium of the second molar. The drawback is that there are high chances of lingual nerve damage, around 1 to 6.6%. Increases the risk of postoperative infection, patient discomfort, and can be used only in young children wherein the bone is elastic. Let's move on to the management, or you can say the classification of maxillary third molars. Similar to the Winter's classification is applied in case of maxillary third molars also, depending upon the angulation. They could be mesial, distal, vertical or horizontal, depending upon the depth as you have seen in the mandibular third molar. Now they are also further classified depending upon their proximity to the maxillary sinus. When a thin bone is present between the sinus and the third molar, it is termed as sinus approximation. Okay, where a 2 mm of bone is formed between the tooth and the third sinus, it is non-sinus approximation. Now, how will you remove an impacted maxillary third molar? In case where the tooth is not completely inside the bone, you can use an envelope flap as you can see in the figure, which start from the first molar, second molar and onto the distal portion is extending onto the buttress region. You will reflect a complete mucoperiosteal flap, do the bone guttering and remove the tooth. But wherein the tooth is very deeply embedded, in that case you need to give an anterior releasing incision. Similarly, the way you have done in the third molar, here also you will give an anterior releasing incision from the mesial aspect or of the second molar or either from the first molar. The bone guttering is done till the cemento-enamel junction, tooth is elevated and removed. Let's move on to the impacted canine. Now, maxillary impaction can be classified depending upon the position of the impacted tooth into 5 types. Class 1, wherein the impacted tooth is present on the buccal side. Class 2, when it is present on the palatal side. Class 3, when the tooth is in such a way that the crown is palate and the root is buccal, that is involving both the cortical plate. Class 4 is impacted in the alveolus between the central incisor and the first premolar, and class 5 where it is present in the edentulous mandible. Now, surgical management, if it is you can use flaps like semilunar flaps, trapezoidal flap to expose the canine area. You can use an anterior releasing incision to expose the canine. Once you have exposed the canine, drill it, elevate it and remove it. If the canine is palatally placed and if it is unilateral, you can raise a flap from canine to canine. And if it is bilateral, you can extend the flap from first premolar to first premolar on both the sides and remove the both bilaterally impacted canine. Now, location of the canine is very important. How do you decide whether it is buccal or palatal? Either you could use a tube shift technique or you can use 2 X-rays in different direction. For example, you can, in case of the maxillary canine, you can use a periapical radiograph. Along with that, you can use an occlusal radiograph, which will tell you the exact position of the canine. Now, complication associated with removal of impacted teeth. Now, complication can arise because of an intraoperative procedure, like while you're giving an incision, if your hands slip, your flap design is hampered. You can injure a blood vessel close to it and there will be a lot of bleeding. Okay? While you're drilling bone, if you're not drilling bone judiciously, you could injure the adjacent tooth or you could be drilling too much close to the lingual nerve. You're destroying the lingual cortical plate. So you have to be careful. You have to use continuous irrigation when you are drilling because bone necrosis can take place since a lot of heat is generated when you're drilling the bone. When you're trying to elevate the root or a tooth, you should always use bone as a fulcrum. If you use the tooth as a fulcrum, you might elevate the adjacent second molar. During third molar surgery, you could damage the inferior alveolar nerve or the lingual nerve because of its close approximation. Let's move on to the complications that are seen post-operatively. There could be swelling post-operatively. That could be bleeding postoperatively. That could be infection, alveolar osteitis, dry socket, or paresthesia postoperatively. Now, swelling is nothing but a body response to injury. When we're doing a surgery, we're causing some amount of damage to the vital tissues, because of which swelling arises. Now, how do we treat it? We treat it by cold compression for the first 24 hours. Now, this cold compression, it prevents the edema, that is, it decreases the accumulation of the fluid in the body tissues. It decreases inflammation. It slows down the metabolism. It controls the hemorrhage. It decreases the excitation of free nerve ending and raises the pain threshold. And it also decreases the enzymatic activity. Okay, we can also decrease pain with the use of steroids. The next complication is alveolar osteitis or dry socket. Now, this is more commonly seen 4 to 5 days after the extraction. Now, this is mainly because of the clot getting dislodged from the extraction socket. If it is partly impaction, we do not put a suture, we put a pack. So the clot may get dislodged either because of infection, or the patient is continuously spitting, okay, or the patient is continuously gargling. Okay, sometimes what happens, we have put a suture also, still suture adhesions take place and clot get dislodged. In that cases also dry socket can take place. It is characterized by, when you see in the oral cavity, there is severe halitosis. Patient will complain of severe pain. There will be necrotic bone and there will be inflamed margin of the extracted soft tissues. Now, how do you treat it? Okay, you need to do debridement of this area, induce fresh bleeding, freshen up the margin. If you are able to suture it, again resuture it. If you are not able to suture it, then put a medicated dressing. Now, this medicated dressing could be zinc oxide eugenol with gauze or chlorhexidine. Now, more commonly, dry socket are associated with gram-negative infection, so you should always give a gram-negative antibiotics like metronidazole. The next complication is bleeding and hemorrhage. If the bleeding occurs intraoperatively with the pressure pack, you can control the bleeding. If the bleeding is post-operatively, ask the patient to bite on a cotton pack for half an hour, wait and watch. If it still continues, you need to explore the area. At the same time, take a blood sample and send for further investigations. Okay, because it might take place like during history taking, you might have avoided history regarding the bleeding disorders. So just to avoid that, take a blood sample and send for investigation. You explore the area. You see the soft tissue. If it is bleeding from the soft tissue, if it is arterial bleeding other than inferior alveolar artery, then you need to cauterize it. And if it is because of the bone, you can add a bone wax to it. Or you could just simply add ab gel or surgiform and suture it again and observe the patient. The next complication is nerve injury. 2 nerves can be injured during third molar surgeries. One is the inferior alveolar nerve, the other is the lingual nerve. The inferior alveolar nerve injury can cause numbness or paresthesia in the area. It could be for a month or for a week. Okay, the main thing is you need to inform the patient that this can happen. And you need to reassure the patient that it is transient, it will settle down with time. It might take a week or a month. And start the patient on neurobion fort. Okay, lingual nerve damage can also take place when you're not protecting the lingual flap, when you're removing a deep-seated third molar. Okay, or when you're doing too much of bone guttering on the lingual cortical plate. So here the patient will complain of drooling, that is tongue biting, thermal burn, change in the speech, slurred speech and all. Similarly, assure the patient this is transient, it will heal, it might take time. Okay, then just with this, I would like to conclude by saying that surgical removal of impacted tooth is a stressful experience for most of the patient. Okay, each patient is different and each surgical procedure is different. So surgeon should carefully assess the risk factor and plan it correctly in such a way to avoid any kind of surgical diagnosis. Third molar surgeries are elective surgery. It is not an emergency. It can be planned and we can avoid these complications and make the surgical procedure more comfortable for the patient. Thank you.